Thank you. Sir is my teacher and guide also, but I take the opportunity of this podium to differ with him. And I'll be talking in favor of against the clear lens extraction. I have no financial interest. So we have taken here in consideration, the patient is 50 years old, the lens is clear, and is immetropic. We are not talking about any refractive error, pre-existing refractive error here. So my choice will be a presbyopic IPCL. And I have some good reasons, because why to disturb a clear lens? Why to disturb the optical system of the human eye? And go for a procedure that is reversible. It has a better predictability. There is a rapid visual recovery, and the adaptation is very fast. Neural adaptation is very fast. And we give the patient a chance for a better IOL option in future. Refractive lens extraction leads to some known complications, and the most dreaded is retinal detachment. There is a higher risk of PCO, because lesser the age, higher the chances of PCO. So we have to tackle that also, and that also comes with some of its own complications. PCR and CME, they are there. Retinal detachment can occur days, weeks, or months after the treatment, and detachments are a feared postoperative complications of RLE. It is postulated that the pseudophakic RD occurs as the reduction in lens volume draws the anterior hyaloid face forward, with vitreous-based traction resulting in retinal breaks. Pseudophakia may also alter vitreous protein composition, accelerating syneresis that leads to PVD. And this is something which is very specific to clear lens extraction, to cataract extraction. The debate of clear lens extraction has been going on since 2005, since a couple of decades, but still it's not resolved. The detachment is, there are a number of studies. The detachment is one of the most alarming and vision-threatening complications of RLE, and we can see that pre-existing retinal conditions, volumetric changes, and young age. These are the three main factors which are considered to be more leading to a complication like retinal detachment. So these are the studies. The most modest increase in RD is reported by Shiu et al., who in their final follow-up study found a relative risk of 2.69 for patients aged under 50, compared with those aged over 60 years. So 50 to 60 specifically is not mentioned, but we can take it around 50 and around 60 years. So a risk of 2.69 is quite a big number. The largest age-dependent risk modification is reported by Pitusis et al., who found those aged under 60 are at 40-fold greater risk of pseudophakic RD than those aged over 80 years. The window is 60 to 80, but you can see the 40-fold greater risk in relatively younger patients than when they are little bit older. Jerem et al. Note that above the age of 50, the risk of RD drops exponentially by just over half for each decade. After 50, the risk drops exponentially by just over half. So this was published in November 24. Here you can see that axial length and age, these two factors are taken into consideration. And we can see with age, the retinal detachment in less than 60 years of age, it's 2.4%, and 60 to 75, it drops down to almost 1/3, 0.65%. PCO, again, is one of the vision impairing complications observed after RLE, especially if the patient is around 50 years old. YAG capsulotomy can increase the predisposition for retinal detachment. And these are other complications of YAG capsulotomy. So do we have any better option? Yes, we have the presbyopic IOL, and that is the answer to this. It is a reversible procedure. If the patient is unhappy, we can reverse. We can remove the lens and after cataract surgery, we can implant a lens. And removal is easier in IPCL as compared to an IOL that is implanted in the bag. Available reverse procedure is still left. A reserve procedure, after it develops cataract, we can remove it and do a cataract surgery. It gives a clue to choose the IOL when needed. If we have put some diffractive or EDOF IPCL, if the patient is not happy, we know that when we are doing the cataract surgery and implanting a lens, we can have this experience with us to decide about the lens that we'll be putting in. It gives a better visual outcome and there is no adaptation time. The recovery is rapid, there's a wow factor, no neural adaptation time, and adjuvant to the natural lens. We are not disturbing the optical system of the eye, we are not touching the lens. So, and the most important thing is the opportunity for a better technology. We can safely presume that more than a decade of opportunity we are providing to the patient, because the cataract naturally it does not happen around 50, but when the patient is reaching around 60, we do get some amount of cataract, and most of them can plan cataract surgery also. And the technology is evolving. We don't have a perfect multifocal, trifocal, or that lens. Every year we see that new lenses are coming up. So why deprive the patient of choosing a better lens 10 years down the line than providing him with a lens that is available now? We know that Restore we are not using Symphony. Many of the lenses we are not using. Every year we are getting new lenses, diffractive, refractive, now some spiral lens has also come. So why to prevent that, why to deprive the patient from that opportunity? And it gives a second option to the patient, and of course a second option to the surgeon also to operate on the same patient. So my preference will be a reversible and less invasive phakic IOL. Thank you.
Patient has got nothing, right? You want to give him cataract? You want to give him glaucoma because of larger size of IPCL? Why, yeah? So I don't think you are justified.
Sir, giving cataract is less dangerous than giving him, putting him at the risk of RD.
RD, you are talking about RD. Let me tell you one thing. Whatever studies you have said, this old age study, and number one, number two, all the studies should be taken with a pinch of salt. Right? Yes. You are a retinal surgeon. If you don't miss a hole, the detachment will never occur. The detachment doesn't happen suddenly. There will be thinning, then there will be a hole, then the water will pass beyond that hole, then it will cause it. So you treat them, yeah? You treat them.
So the younger patient, usually they don't have... Yeah, just one line. The younger patients around 50, we don't see PVD in most of them. There's no PVD. If the PVD is not there, that patient is always at a higher risk of developing RD if we are doing clear lens extraction. The reasons, because the volume is less, the anterior halide surface, it comes forward. So we are putting him more at a risk. And we are not talking about the competence of the surgeon. We have taken into consideration that the cataract clearance extraction is also done by a competent surgeon, and presbyopic IOL is also being done by a competent surgeon. So there's no comparison in that. So taking into consideration.
Yeah, well,
thank you.
I think I'll give my opinion, like 50 years old clear lens. I do agree both of them. Both of them are my friends also. That is first point. I agree with both of them. Again, 50 years old patient with a clear lens extraction, if there is no cataract, if the ACD is very deep, and all other parameters, all the investigation over, rather I prefer to do with the phakic lens, not phakic presbyopic lens. Rather I go with the phakic lens by doing the micromonovision in the other eye, because IPCL phakic lenses still yet to be proven. I had used around 10 to 12. The amount of glare and halos is quite much higher compared to if you do a non-dominant eye micromonovision. But again, now I'll talk what Sir spoke. 50 years old patient, suppose their ACD is almost like a 2.8, 2.9. That means as the year goes on, the ACD is becoming lower and lower. That time, still option is there according to the company protocol 2.8. Still if they are having 2.9 also, I will not go with the phakic lens. Rather, I will go with the clear lens extraction. Because now, if you see, of course, I do agree with that year and year, new lenses are coming. But still, I think if you see the last 6 months, most of the company people are going towards the good EDOF lenses where there is no rings in that lenses. Provided if you, of course, in spite of treating retinal, the patient might be having a holes with lattice degeneration. In spite of you do the barrage laser, still the incident of RD will be there. That's everybody understood. But still in such cases, touch and go ACD situation, no cataract, still I think clear lens will have a more value than more suitable than the phakic lens. But if the ACD is 3.6, if the ACD is 3.8, that means as the age grows for another 10, 12 years, it may not come down up to 2.8 or 3. Then again phakic lens, because the one advantage with the phakic lens, you are putting the lens exactly in the nodal point of the eye. So always whatever the vision they get, always better than what we tell them. But
I think the condition is emmetropic. That is what is presumed in this. The patient does
So
not have any
hypermetropic-
refractive error.
hypermetropic 50 years, definitely no way we can think about phakic lenses, because normally they'll have a shallow entry chamber, then you have to go with the best with the lenses, EDOF. If the patients like mesopic pupil is small, then of course you can even think about ring lenses like trifocal lenses.
So it was presumed that the patient
Yeah.
is.
Oh, so both of them is win. Both of them are the champions in this.